Welcome to the 3030 Health Podcast. The following discussion is for education and entertainment. It is not intended to diagnose or treat disease. Please do not apply any of this information without first discussing it with your doctor. Here is your host, Dr. Ruiz.
Hello everyone, super excited about my guest today. My guest today is Dr. Tom Moorecroft. Dr. Moorecroft is a global leader in solving complex medical mysteries. He calls himself a medical detective. His goal is to find what's really keeping someone sick and help them get better. He has been treating patients with chronic bacterial and viral infections as well as mycotoxin illness for over a decade. In this episode, we share a lot of tips on how to improve your immune system and how to help protect yourself from infections. I will be releasing season 1 of the 3030 Health Podcast on May 19th, so stay tuned. I hope you enjoy the show. Hello everyone, super excited to be here with my friend Dr. Tom Moorecroft. Tom, how's it going, man?
It's pretty good, Guillermo. Thanks for having me on. It's a blast to have a chance to talk about all this.
I know, and you've been everywhere, and a couple of weeks ago, I did my own version of the COVID-19 podcast, explaining what it was, explaining, from a more like natural medicine and plant theory, and I want to have the infectious disease expert theory out there. But before we start, what's your hero story? How did you get into this space, and how you doing, man?
It's kind of interesting. I mean, I try to look back and think of the key moments, and really what it boiled down to was I was on a hiking trip in college when I was studying natural resources. I was, all I wanted to do is play outside and save the planet because I was just a, kind of a tree hugger, really into the science, but also into supporting life. And I was out on a hiking trip for the weekend, and some of the quote unquote leaders were kind of not really leaders. And they ended up, I got lost because of a big string of events, including them telling us not to bring water for a short hike that turned out to be long. And in the end, they thought I was playing a trick on them, and they played a trick on me. And by the time I got back down the mountain, I had a hard time walking for the next 3 weeks. And I said to myself, this shouldn't have happened. I want to learn how to prevent this. And I also know that when you're doing things you love to do, particularly in the out of doors, sometimes people get hurt. So I started wilderness medicine training, and I was instantly hooked because it was really those two things. It's let's prevent the issue if we can. And if we have something happen, let's apply the most common sense approach to it. And wilderness medicine really came out of when you're stuck in a situation where you don't know what's going on and you can't get to a hospital quick enough, the stuff we would usually do in the ambulance or the emergency room doesn't always apply. We have to think about it differently. And so I just got I just loved it. I was addicted. I was I need to learn more. I love the leadership part. I love the medicine part. So I started working on the ambulance to get experience, and I worked in the emergency room. And at that point, I was just really hooked on learning more about our body and how it functioned, its ability to heal itself. And then, so that kind of got me going. And then I ended up in osteopathic school because I followed my heart, and I didn't really even know what was going on with osteopaths at the time, but I just knew that they were different. They were more down to earth. They were very open and welcoming, and they had the hardcore science, but also that people side of them. And so, I did my training, and I really fell in love with osteopathic treatment and the philosophy of supporting the self-healing mechanism within the body, and also addressing both body, mind, and spirit, not just picking one part of it as a separate thing. And I was in private practice, and I was doing osteopathic manipulation one day with the patient, and I very clearly remember feeling this person has an infection or something like that because I can't fix this with my hands. And I didn't know who to send her to, so I did a little research, figured out what to do, and diagnosed her with Lyme disease and some co-infections, and then I started treating her. And I guess I got good at it because after that, there's just a whole slew of people coming in for that kind of stuff. And so I really dove deep into healing chronic infections.
One big thing that you mentioned there is common sense and how different things have to be treated in different ways at different times. There was a study out of Israel. And, I don't know if you knew this, but I used to work at a level 1 trauma center for kids too.
Nice.
Yeah, so
that's
dude,
where I started too.
yeah, so it's funny,
Right
it's
on.
like that's why we get along. We're adrenaline junkies. But this study out of Israel, they were like, you know what? What if we put a doctor in the ambulance? And they were tracking, and they had to stop the study because too many people were dying. And what was happening?
Exactly.
What was happening is that doctors were overtreating. Instead of going to the end care, going to the trauma room for blood pressure stabilization, they were trying to do it on the field. And it just doesn't work. So something that might seem like a good idea, let's get a doctor in an ambulance, can become catastrophic. And I think that we see a lot of lack of common sense with this global fucking pandemic we're going through, because you hear so many things, like, oh, it's just a cold. Well, it's just a cold until it's not a cold. And then we have a slew of conspiracy theories that, we're probably not going to get into because it's just like a wasp's nest, But I'm going to ask you the stupid questions so people don't have to, okay? So if, there's like, I'm raising my hand for all of you guys out there that either don't have access to an infectious disease expert, or maybe you're too afraid, or you're just confused because you have all these things coming on your social media feed that you don't even know where to turn. Is this just a common cold?
No. It's interesting because there are 4 human coronaviruses that are known to cause the common cold, with the other kind of 2/3 of them being rhinoviruses. But this is a different type of coronavirus. Looks like something like 96% of the genetics are identical to a bat coronavirus, so that kind of jumped over. But it's interesting. I mean, when you look at what's going on, it looks like a really bad flu, like influenza, but the statistics are different. We're seeing more, the mortality rates we're not really sure about because we don't know how many people really have it, right? So we're seeing this number of like 3.5% is always kind of the general number that the US has been at for mortality rate. But the issue around that is that's like known cases and known deaths, and we don't know anywhere near all the known cases. But what I will say is the original SARS-CoV virus back from the early 2000s was a bit different, and it definitely led to more mortality, at least it appears to so far, but it really was not as robust as this. There's something about this current virus that is more robust. It's more easily infecting humans. It's spreading more rapidly than we think, but it's definitely not just a common cold. However, I say that a little bit holding my breath because right now we're looking at these what appear to be really huge and scary numbers. But the reality is that number of 80 to 85% of people will have mild disease and still be okay is holding true. And in the end, I'm hoping that that's more like 90 to 95% of people who are infected have mild to moderate disease. And if that's the case, maybe in 4 or 6 months or a year when we have more data, I'll be saying, yeah, you know what? It kind of was like a common cold. But the one thing I've said a lot through this is there's so much that we don't know, but I'd like to go back and look at where we started, right? Because you talk about working in the ER. I mean, in a level 1 trauma center, which is where I cut my teeth, so to speak, in the beginning. And
were you an EMT?
Yeah, I was an EMT in the ER.
Me too.
Nice. And then so after that, though, I'm like in medical school, I was like every rotation I could take in the critical care unit I took. In residency, I almost switched to anesthesia critical care because I love the way you have to take the best evidence you have, make a decision, and help the person in front of you, but also then go back home and say, well, okay, that was what I did for the one person in front of me. But then what do we need to do for the whole population? And can I learn for the next one person who came in front of me? So I think a lot of what we're seeing today is on the news is we're seeing what the doctors are doing for the sickest of the sick when they're in a MASH setting. They don't even know what to do, right? But think about this. Every year we have an influenza pandemic, essentially. There's anywhere in the US, anywhere from 35 to 60 million people will get influenza, requiring 500 to 750,000 hospitalizations, sometimes closer to a million. So if you take like a bad influenza year, the ER and the hospital system is about to fall apart. I mean, we are bursting at the seams. So let's say that the current COVID-19 pandemic in the end turns out to be no worse than a bad seasonal influenza. You just drop bad seasonal influenza on top of another bad seasonal influenza, and the medical system collapses. So part of, I think, what we're seeing is we don't know what to do, and two, the system is already about to fall apart before this even happens. So we're just stretched so thin.
And I'm gonna kind of translate that, to like a personal story. So 3-4 weeks ago, my parents who live in Texas developed a mild cold. My dad lost his voice. My dad had some digestion problems, some diarrhea. My mom had body aches and fever. And at one point, she gets on the phone and tells me, I can hear my heart murmur. Now, she has some, a pre-existing condition. Yeah. So I'm freaking out, dude. I'm freaking out, and I'm like, okay, I'm calling the ambulance. And she's like, nope, I'll be better tomorrow. If by tomorrow I'm not better, I'm going to go to the doctor. Thankfully, next day she breaks the fever. And this is very early in the lockdown situation. So I'm calling the Department of Health in Texas. And they're like, nope, we're not swabbing, because if she comes to the hospital, she's going to expose a bunch of people. And if it's just this quote unquote mild cold, Tylenol and rest is the only thing that we know what to do. So she's better off not getting exposed by hospital workers or anyone if she stays at home. I didn't write a prescription for hydroxychloroquine. I didn't tell her to mega dose mushrooms. So she stayed at home. Fast forward to April 9th. I get a call from my dad. Hey, your mom doesn't feel well. Now, she has pre-existing conditions. Her blood pressure was 2 something over 1 something.
Oh, my God.
She's taken 2 rounds of nitro, and she can't feel her arm. So I'm like, what the hell? Dad, what are you doing? And he's like, well, we're driving around to see if it passes. I'm trying to distract her. And I'm like, Dad, go to the hospital.
Hospital. Yeah.
So she's fine. She spent 2 days in the hospital. They were scared that she might have had a heart attack or stroke. She was in the stroke unit overnight. She never passed out. She felt very weak, but never lost consciousness. What's scary is a series of events. My mom ending up on a high acuity unit, taking away resources. My mom being terrified by herself. My dad couldn't even enter to the triage room of a hospital because of this infection that's going around. And the repercussions of everything, because our medical system is not capable of taking care of so many sick patients at once. And my mom was scared to go to the hospital because she's like, I'm going to get infected. Well, Mom, you're going to die of a heart attack.
Well, right. But this is what we're running into, Guillermo, is like we are so afraid of coronavirus that, we're afraid to go. And, I think your mom, of anybody, high blood pressure, depending upon your age, I mean, your risk just goes so up with high blood pressure, and other pre-existing conditions. And so then you're like, and then you're in a hypertensive crisis. Like that's a good way to get a heart attack or a stroke or worse. We see that we don't know really what to do, in terms of how to handle this because the system is just overwhelmed. I mean, crap, in the middle of the summer when you have no influenza and you have no coronavirus, like let's say last summer, it's still going to be hard. People are going to come in and wait in the emergency room for a really long time. I know people like your mom would get triaged to the front of the line, but it's crazy that we have to be in a situation where we're worried about this. We're like, well, I don't want to go to the hospital because I could get COVID-19 and die, but I'm also, if I stay at home without proper medical care, I could die. And I saw a report where, and granted, it's just one person and it's a sensational story, but a nurse anesthetist was about how to intubate somebody who was, having respiratory distress from COVID-19. And then the next thing you know, right before they do the procedure to put the breathing tube in, the person looks up and says, "Who's going to pay for this?" And he was the person, instead of getting proper care, in his mind going, "Okay, I'm getting the right care. I'm going to be in the right place so I have the best chance of survival," is worried about his family having to pay for this intubation that they can't pay for.
Yeah. Yeah. And that's where I want to go back to this whole thing about common sense. Okay, because there's a lot of keyboard warriors just typing away at click, saying either this is a common cold or this is nothing else. We shouldn't, we shouldn't be doing this or that. We shouldn't be having a lockdown, or espousing, all sorts of remedies or cures, or saying how hydroxychloroquine is like this miracle drug. And we kind of jumped into the podcast because we started talking about hydroxychloroquine and how if we were in a situation where we're on the front lines, we would use it.
Yeah.
And now right now, I'm about to ask you, why shouldn't we just prescribe everyone hydroxychloroquine? And I think what's happening is that people that are not full-on practitioners, people that don't have a license, people that don't know what the burden of going to bed at night and thinking, did I fuck up with my patient? I hope my patient is better tomorrow. Or you wake up the next day and you call a hospital to check on your patient. People that have never experienced that don't know how difficult it is to make a medical decision, because medicine is not black or white.
Yeah, I think that it's an incredible point that everything's so sensationalized, because we're afraid and we don't know. And our medical system has trained us to think we know things. Most of what we say we know, we don't know. Like 9% of medicine has really good evidence, another 10% has decent evidence. The other 81% is art. We're using the best information at any given time. And in this, I mean, this is like completely so different. And like the other day, like I think it was last week in Connecticut, the governor said that like a newborn or a very young child, 1 or 2, something like that, died of COVID-19. And my heart went out to everyone because the baby died. And I said, it's probably SIDS, because it's it's sudden infancy death syndrome. And I bet you had nothing to do with COVID-19. And they swore up and down it was all COVID-19. And now everybody's like, oh my God, these little kids are going to die of it. And then just yesterday or this morning, like my wife is telling me, oh yeah, the governor said that he made a mistake. The baby was not positive for COVID-19. I'm like, you just, for a week now, all these people are thinking this little young child died of COVID-19. But it was like we're so afraid that we don't take a deep breath before we act, And what's interesting to me about the hydroxychloroquine is there's a lot of cool thoughts about how it could work. Anything from it's known to increase the pH on the surface of the cell membrane. So when you're thinking about like that ACE2 receptor that the SARS-CoV-2 virus has to attach to, it may inhibit fusion of the virus to the cell and therefore make it less likely to infect you. And then it also has some other sort of direct antiviral properties and all that other stuff.
Can you talk a little bit about like where it came from and what we usually use it for?
Yeah, so hydroxychloroquine is actually an anti-malarial drug. So it's used to treat, malaria. And it also is used as a DMARD, sort of disease-modifying anti-rheumatologic drug. Fancy way of saying we use it for things like, lupus and sometimes even in rheumatoid arthritis and other autoimmune conditions.
Especially like with skin involvement.
Yeah, and what's also interesting too is in the treatment of chronic infections and say like Lyme disease and other things, a lot of physicians use it for 2 reasons. One is because it increases the pH inside the cell or makes it more alkaline. It's kind of the opposite of the infection, which tends to be acidic, and it allows things like azithromycin or other antibiotics that work inside of cells to theoretically work better. The other thing it's an immune modulator, so it's very anti-inflammatory. So sometimes when people have like joint pain or other inflammatory issues, we use it there as well.
Yeah, and it's derived from plants, from the cinchona bark. So that's kind of cool.
Right. Well, it's so interesting to me that almost everything is derived from like nature, right? I mean, we synthesize it to make it easier to make, and then the cheaper and easier it is to make in a lab, the more money the company makes, and also maybe you can make sure you have the purity you need theoretically until you add all the additives to make it pink or purple or red. But
my school, the Southwest College of Naturopathic Medicine, our lab, we're screening 30 different herbs right now as we speak against coronavirus. And we've been testing plants against coronaviruses since before 2017. So this is not new. I just read an article the other day that Wimbledon has been taking pandemic insurance for like the past 10 years. And they're about to make
use it.
Yeah, like $240 million on a $2 million investment. So we
Wow.
knew that this is going to happen. I've been talking about like the use of antimicrobials against bacteria, and our rampant use of antibiotics, and how, we're creating and training bacteria to become resistant, and that's going to be a problem. I've been talking about this since 2014.
Oh yeah, and I think one of the other issues that come up too, Guillermo, is that we are a society in general, and I'm assuming the people who listen to your podcast and the people that you're treating and the people that I'm treating for the most part don't fall into this category, but some certainly do. It's like we're looking for the silver bullet. In any infection, you have two main things going on. You have the bacteria or the virus, the pathogen, and you have the host. And so what I'm suggesting to the general public right now is to leave the viral component of this to the experts, to the researchers, scientists, the doctors. Let them figure out what to do with that. If you're the host, my goal is to allow you to become the best version of yourself, the best, healthiest person you could be. So you are literally the world's worst viral host. Because it's on both sides of the road. And I think we do need to understand that no matter what we do, we could still be exposed to this virus and get sick. But a lot of the treatments that people are looking at are things that should be in our diet and our lifestyle already, including just, all theories on melatonin and the inflammasomes, and even just like nitric oxide and inflammasomes. I mean, there's all this cool stuff out there, but if you just were to sleep well and do some, things like Wim Hof breathing or Buteyko breathing, where you sort of mimic to some degree altitude, and you breathe a little bit less so that you get a little more carbon dioxide, and this triggers really cool stuff like the creation of nitric oxide in the sinuses in your face. And one of the fringe benefits of that, in addition to this whole nitric oxide through your whole body, which may help in viral things and in health in general, is it opens up your nose, which then allows more brain detoxification through the glymphatic pathways. And it's just really interesting to me that the medicines that we're focusing on are critical, because if you get sick, we need to have something, whether it's a natural medicine or, a pharmaceutical, but most of them are coming out of or being coupled with the use of natural products that should already be in our system. Like we're talking about hydroxychloroquine. There's a lot of cool ideas about why it may work, but it also is a zinc ionophore, so it helps zinc get into the cells. So if zinc gets into the cells, it can help stop viral replication. Well, the problem is I can give you all the hydroxychloroquine you want, but if you don't have enough zinc, either through supplementation if you're sick, or preferentially having zinc in your diet, how are you going to do that? And we know that quercetin works as a zinc ionophore, and there's been research against coronaviruses since in the early 2000s. And this, again, we can get from food. So it's just interesting to me that we can help the host and we can fight the virus with a lot of the same strategies.
And that's where we are. We are running a credit on our health and we're trying to pay month to month. And now that we have an injury, we don't have any capital to repay it. So that's what we're doing. And we have this makeshift system of medicine that hopefully, as a silver lining out of all of this, will second guess our strategies and we'll try to do something different. It's very interesting, what you're talking about with the hydroxychloroquine, making things a little bit more basic, more alkaline. And then, we know that it reduces your immune system. Very early reports of this hydroxychloroquine, azithromycin, methylprednisone treatment is, so these people in China where they had their lungs full of fluid, probably tons of bacteria and virus in this fluid, and they were given a potent anti-inflammatory in the form of hydroxychloroquine and methylprednisone. They were given, azithromycin for bacterial infection. So at that moment, at that very critical moment, it makes total sense to me that cocktail would be better than a different cocktail. And then within that same paper, they warned about the use of DMARDs and prednisone, before you got into that critical stage. Because if you have lower immunity, you're likely to get a worse infection. So, and that's what I'm talking about when I talk about medicine being gray. So you have one paper telling you if your patient is on prednisone or methylprednisone and they don't quite need it, you might want to reconsider taking them off of it right now, because that might predispose them to a bigger infection. But these are walkie-talkies. These are people that are not sick, that are haven't been infected. And then within the same paper, it says, and our best results from getting people off of respirators was giving them potent anti-inflammatories. And people scratch their head and they're like, you're a flip-flopper.
Well, and the problem is what we're trying to do is we're trying to apply treatment of an individual and then come up with an idea for the general population. And this is actually, if you work in a critical care unit, you'll see 5 people who come in with all the same diagnosis, so to speak, and you'll end up treating them all differently. Now, it'll have the same flavor, but when you asked about, is this like a common cold? I'm like, man, I wish it were like that. But you know what? It's kind of, there's some really unique things. And when you look at, we've been talking about the ventilators and stuff. People get on these ventilators. Typically, when you're in the critical care unit, and you have the acute respiratory distress syndrome, the ARDS, as everybody's been talking about in the news. I mean, 35 to 45% of people are not going to make it. Kind of depends on the severity. So, even if you call it 50% of people will come off the ventilator, 50% of people won't. The numbers we're seeing for COVID-19 are like 80, 90. I've seen even estimates of 95% of people not making it, and people are like, well, why are we even trying? And then there's this new discussion of, well, maybe it's not really ARDS. Maybe it's just hypoxemia, low oxygen, right? And then they start talking about methemoglobinemia. And again, it's one paper. It hasn't even been peer reviewed yet. And then there's some couple case reports, but they're all saying, hey, like, we want to use hydroxychloroquine or chloroquine because of all the other things we've talked about. But then the problem is these are medicines that can actually cause this methemoglobinemia, where we have a change in our hemoglobin, and now it's no longer able to carry oxygen. And so there's some research that says the virus may be triggering this. And then there's other research that, it's very clear that one of the most common causes is chloroquine. And it's very rare, but it can happen in hydroxychloroquine. So it's like the virus may be causing you to not be able to have oxygen, and the treatment may be able to cause you to not have oxygen, So then people jump to, hey, let's use the treatment of methemoglobinemia from medicines to treat the virus with this. And it's just like, we just, that whole Poof a Miracle Occurs cartoon that you see,
Yeah.
It's kind of always like that. I'm like, let's just throw in some methylene blue here, and it's like people just come up with an idea and they're trying to help, but it's not always thought out. And we see a lot of, what we call N of ones, a lot of case reports. The number of people in the study is one, and we're reporting what we did. But what we really need to do is get larger studies to tell us what's going on. And one of the things, I'm sure you've noticed this, is we have a lot of we're holding off on testing except for the most severely ill people. So we have a selection bias. We're only testing because we have not enough tests. We're only testing people we have to decide what to do with them. And we want to say, hey, is it SARS-CoV-2 or is it something else that we have better idea of how to treat? So our numbers are grossly skewed. And if you look at like Iceland, they did random samples across the country and their numbers don't look that bad. And so the question I've said from the beginning, I think that the coronavirus outbreak and the pandemic is going to be not as bad as a lot of people are thinking with the hysteria, but it's going to be a lot worse than what other people are thinking. So I think the truth of the matter is going to be somewhere between the extremes that we're seeing. But it just, it's hard because I know as a critical care trained person what I need to do with one person or 10 people in front of me every day where I have to do this. But that doesn't necessarily apply to all of us who are home, who are, like you said, walking and talking, and we're upright.
And just as a clear personal example, my mom had all of the symptoms. She never got tested. And then she had some, cardiac event happen afterwards. So I think she had it. We'll never know. She was never swabbed. And that's one person that fell through the cracks, and we'll never know what happened in that case scenario. So we will never know the exact extent.
We traveled as a family, third week of January, and we went out to Hawaii for business, but also we did a few family days. So we took, my wife and I took our daughter, who's 10, with us, and we got back, and man, like a week and a half later, I was so sick. I was like, this is the worst flu I have ever had, and I don't usually get the flu. I was dying. I had a horrible cough, a little bit of shortness of breath, nothing crazy. I was like, I think I have a fever. And, my Oura ring said my body temperature went up like 3 degrees overnight. I'm like, I'm usually minus, And then my wife gets sick and our daughter never got sick, right? And so then both of us, as soon as we started to get on the mends, the COVID-19 thing really blows up. And both of us are like, I think I already had it. So I would love to, and I know that they're working on it. There are some specialty labs offering antibody testing, and I know there's larger commercial antibody testing coming out, because I think it's going to be so important for us to know who's been exposed, because if push came to shove and the local hospital needed me, I've got the skill set, I would go do it. That's what you do. But when they're kind of doing okay and they might need some extra help, and I also still have a full patient panel and a family who's currently healthy, do I want to go put myself at additional risk? I don't know. But if I had antibody testing that said that, one, I'd been exposed, and then we could then figure out, if we do have antibodies, are we truly immune, at least for this year, then, I could go back out. Maybe I could, do some other volunteer work in the community. I could go out and go to the store, and other people wouldn't think that I'm going to, be a ticking time bomb and make them sick. It's like, we really need to improve our testing, both with the PCR testing for acute diagnosis of active infection, but then antibodies, I think, are going to be the critical piece for figuring out when the heck we can get out of our houses. And Dr. Fauci's even been talking about maybe giving people almost like a papers, like a you've been exposed card, so that you could go out in the community. And I don't really think that that's going to fly so much with all of everybody wanting to protect their personal rights. But I would like to be able to flash a card and say, hey guys, look, I'm not going to make you sick. Oh, you're not going to make me sick. So, and I think, dude, the amount of people in the very beginning of this, they were doing estimates that 10 to 49 times the number of cases were actively infected. So, if you look at today, we have 500,000 cases. Could you imagine? That would be, if it were only 10 times greater than this, that would mean 5 million people in the country already had it. But, it could be as high as, 50 or 100 million people, right? And so if we were getting closer to those kind of numbers, we would start to have some hope that there's a break, because once we get to about 50, 60% of the population being exposed to this, we're going to start to potentially experience that herd immunity type of phenomena. And so I think we really need to know more about the true positive exposures from, that aren't getting tested.
And all of this is theoretical. We have no idea. And I can see someone, misconstruing your words and saying, oh, 60% have already been exposed. Like you were very clear with your message that we don't know, that we wish we had, testing to know, and that, there is a possibility that 60% or more have already been exposed in one way or another.
Well, what I'm saying is I think the exposure is a lot less than that, even when we get the true number, but we estimate we would need about 60% of people exposed to develop that herd immunity. The problem is if you have antibodies to COVID-19, to SARS-CoV-2 virus, I know that you've been exposed. The next part is that does not mean you're immune. We don't know.
We don't know.
We think it does based on monkey studies and human experience, but we really don't know because we can't even figure out how, we can't get a cohort of people who are asymptomatic with positive antibodies. So we don't know. We think it's going to work that way. But if you go even conservatively, whatever, you've got 2-3 million people exposed. Well, we're nowhere near we've got 330 million people in the country. So we're going to have to approach like 150 million exposures to actually even get close to that protective number. And hopefully that's unrealistic. But like you said, we don't know because we don't have the data. And it's all speculative.
And then, there are companies that are coming up with their own IgG, IgM panels for this, and they're being fast-tracked because the FDA has some special rules right now because of the global pandemic. So maybe you have some low-level IgM towards this. Well, we don't know if the test is accurate. And B, we don't know what the titer what threshold we need to hit in order for us to be immune.
Yeah, and in some viruses where we know that you get the IgM and then the IgM becomes IgG and we get some immunity, some people who create a low level of immune cells against the virus will do fine and they'll be pretty much protected, and others they won't be. And then the other question is like the original SARS-CoV virus from 2003. I mean, that kind of burnt out, which was great, just kind of like Zika burnout. But, as a quick side note, like look at all that happened with Zika, right? Then they finally were able to test for it, and they found out that a lot of Central America was already exposed to it. So it was like we became aware of Zika, so we freaked out, and it turns out that, yes, there were some really bad outcomes, but the percentage of bad outcomes compared to how many people were actually ill was grossly different than what we had stated in the urgent epidemic time, right? So it's like we overreacted because we didn't know. And the reality of this thing is it looks like it's worse than influenza, but we just need to know the numbers because and we're sampling like New York City hospitals, great place to sample if you want to skew the data towards really sick people who aren't going to make it because you're only testing them. And the other thing we've known for a really long time, I mean, I've been talking about this at least since the middle of February, if not sooner. This thing has asymptomatic viral shed, just like influenza, meaning you can have no symptoms of the infection, you can have it, and you can pass it to other people. And so we don't know. Maybe a lot of our children are asymptomatic carriers, meaning they'll never get sick, and they just give it to other people, like their grandparents who are high risk. So for all we know, this thing, hopped into humans, November, December, which is what it looks like, and it just spread super rapidly, and lots of people have already had it. Again, it's speculation, though. That's the problem, is we're trying to do the best we can, and like I said earlier, the truth is probably somewhere in the middle.
Yeah, and then, let's step into the wasp nest for a second, okay? Because I do work at a virology lab that specializes in herbal medicine against viruses. So I might know a little thing or two, And then the other thing about this lab is that we create vaccines. And, we've been working on a vaccine against pox for many years.
Like an herbal vaccine?
No, like a real vaccine. Yeah,
regular vaccine.
Yeah, so basically,
whoa.
yeah, so basically what we do is we look at traditional data on herbs, and then we try to figure out what the actual component of the herb is acting against the virus, and then we kind of purify those components to try to make herbal medicine better. And then we investigate those pathways to try to find novel vaccine targets, basically. But, what do you think about the vaccine? Do you think we'll have it by December?
No. I know that I was telling you earlier, there's a report out of England saying that they're so sure it's going to work. They'll have it approved by September. So they're asking the government for a grant to start creating it ahead of time because it looks so good, and that way as soon as it's approved they can just have it rather than have to and give it to people rather than looking to start production after it's approved to get it out quicker. And I don't know, we've got like three main ways to make vaccines. All of them typically take a very long time, and I know we've been talking about 14 months to 16 months as a realistic timetable. That is obscenely quick from what I understand, and 5 or 6 or 7 years is probably more realistic. And we could turn something out, but the question of safety and efficacy is really up there. There's been some people who actually are very big pro-vaccine people who design vaccines, make a ton of money on vaccines, saying that they would not take a vaccine if it took any less than 5 years to make, just because of the safety issues. And it's interesting, though, because some people are there's that one company trying to make a messenger RNA vaccine, to try to reverse engineer, build the vaccine from the genetic material. But they've been doing that in animals for a while. But with everything they've ever tried in humans, it's never worked. So now they're like, well, we're going to make it work now all of a sudden for COVID-19. I'm like, oh, maybe. And, the thing with the vaccine is, we don't know if SARS-CoV-2 is going to be like SARS-CoV Classic, the original one, where it's just going to burn out and we're not even going to have to worry about it. It's going to be pretty much gone. Or if it's going to be like the seasonal influenza viruses that mutate every year and we're going to have a new one. And so we just vaccinate to try to take the edge off, So I don't know. I mean, I think that if this thing sticks around, having, for more than a season or two, we're definitely, having a vaccine has the potential, if it's done well, to be very helpful. But as we've seen with different versions of the influenza vaccine, some are better than others. And my concern always is some of the additives, too. But we need to do something different, it appears. But again, it's hard to make. This is where I think it's really important for everybody to understand. Like, I'm having a hard time answering this question because I'm like, we don't know enough information. And if SARS-CoV-2 burns out in a year or two, then we don't need a vaccine, right? But the problem is, if we wait a year or two to see what the lay of the land truly is, we're going to be 2 years behind on making a vaccine, and we could lose hundreds of millions of more people, right? And it's like, so it's kind of a complex thing. I think it's a reasonable thing to be looking at, though.
I put it on you because I work at a vaccine lab, So I am very open about being okay with vaccines, as my personal choice. And my only job as a doctor is to educate and have the patients make the correct decision. As a doctor, I believe that I need to take vaccines, for like the seasonal flu and stuff like that, so I don't expose
Give it to other people.
My patients, yeah. Patients that we see are sometimes immunocompromised or taking drugs that make them immunocompromised. As a little side note, one of the things that we've looked into is natural adjuvants. Okay, so the mercury being an adjuvant to incite an immune response. We were looking at papers from traditional Chinese medicine. We started with pox, which is a DNA virus. In China, they would collect the scabs of patients with pox, and they would grind them into a powder, and then they would put a plant into this mixture, and then they would snort it. And what we found is that the plant that we're using was Ferlaria. and it causes kind of like an immune response with the addition of the pox virus. So now you're having, this kind of like early creation of a vaccine against pox, and it wasn't very effective, but a lot of people, would get the pox at a lower level. So we're looking at, we're looking at things, and this is, dude, I've been working there since 2014. So, we've been interested in plants and their, antiviral properties for a very long time. And we've been looking at maybe what if we switch the adjuvant from mercury, thimerosal, to something natural like filaria. And what we've discovered is that we sometimes have really intense immune responses. And that's where the problem with a lot of vaccine side effects happen. So even if it's natural, that doesn't mean that it's without risk. Like I said, I am very open about vaccines, and me not, I don't have any kids, so I don't have to make that decision. I don't talk about vaccines with my girlfriend and her decision making because I don't want to influence her. I want her to be the one making that decision. I just educate, and I know that they are not without risk. And a very clear example is back in the 90s when the rotavirus vaccine came out, because diarrhea kills more people every year than coronavirus. So they developed this vaccine for rotavirus, and a side effect of this vaccine was intussusception. And that's when your intestine kind of telescopes inside of it in itself, and it starts digesting itself, which is a very big problematic emergency situation. So a lot of kids had this, this side effect, and ended up either having surgery or being really ill in the emergency room. And that was a vaccine that was kind of like really sped up through the system. So I'm not here telling you that vaccines are without problems. Specifically, something like a new technology like this mRNA vaccine, sometimes, usually vaccines are created with a particle of the virus, and then it's kind of like a training camp for your immune system where they recognize this and then, oh, I know this guy, and they start attacking it. Well, when you create a new vaccine like mRNA, well, we have mRNA too. What if your immune system gets confused and then you start attacking other mRNA that might be very necessary for your life? And this is all what ifs, this is all, we don't know.
Which is why we do this we do the study process. That's why there is a whole long procedure to bring it to market, right?
Yeah, and this is brand new technology. So even if we had a 100% successful vaccine, we have the product chain to create the type of vaccine like the flu vaccine, the type of, we have the instrumentation and we have the technology to create that type of vaccine. We don't have the technology to create mRNA vaccines. We have the technology. We don't have the production technology. We don't have the widespread infrastructure to have that vaccine mass produced and then distributed. So even if this mRNA vaccine was successful, we wouldn't see it at your local pharmacy for years because we don't have the ability to mass produce it. So that's why I'm a little bit more hopeful of the other type of vaccine, the fragment type of vaccine, because at least we have the infrastructure to create it and we have a little bit more experience with it. I think in the end, this mRNA vaccine, we'll figure it out, but I think it's too early to call it, that this is going to be the way that we go with this.
And one of the things I'm concerned about too is like this, everything is a rush right now. And we know that when we rush things to we know that when we follow the typical drug or vaccine, kind of creation protocol, we go through all the different steps, phase 1, phase 2, 3, 4, whatever, all of the different studies. And we check off every single box that like the FDA makes us and whoever else. We know that still we have to do kind of like post-production, post-marketing. Once it gets out into the public, we have to do this post-marketing follow-up to see when we actually, use it more widely, are we still getting the same result as we did in the study? Because we find that a lot of drugs that doesn't, and vaccines that doesn't occur. So I don't want us to skip steps because of fear. If it's an appropriate step to that we can take that step and quickly analyze and say, yep, we've done a good job here and move to the next, that's fine. But there's a saying coming out of the emergency room in critical care is slow is smooth and smooth is fast, right? And it always sticks with me. That's why we have to take a deep breath and remain kind of as calm as possible, and let's proactively look at what we can do. We don't want to get into this fear-based decision making or, oh my God, we have to go really fast. Because if you go really fast, you screw up, and I'd rather, literally if you take the vaccine development process and you maybe understand the significance of what's going on in the world and we want to push a little bit, that's fine. If we need to do more studies and put more money into certain studies for medicines to help combat this, and kind of put a push in that direction, it's fine. But let's not run and trip over our shoelaces. Let's not skip steps, because then in the end, people are going to get hurt. And particularly with vaccines, I'm not opposed to vaccines. I would like better adjuvants if they were possible. And there are things you can do, but my big thing with vaccines are, I don't think personally that we should be giving 1,000 vaccines at one time. I think because you highlighted the idea is it's like a mini training camp. So I just had this thought, like, next thing you know, we're going to have an influenza combined with coronavirus vaccine. And I'm like, maybe 2 is okay, but we're getting to like trying to give like 6 and 7, 10 vaccines on one day to a kid. And most will do okay. But what about the ones who we could have spread it out a little bit? So again, it's not that we need, to fix the vaccine world or even, but it's just about applying common sense. If we want to have training camp, when I go to an athletic camp, I don't do every single thing on day one, because then I won't be able to move for the rest of the camp. I want to just stagger it out, I mean, 'cause how many people have been, taken a little bit of time off the gym and then gone back in and hit it hard, just like they hadn't taken 3 weeks off, and the next 2 days you're like, you can't move your arms and legs.
My favorite example of that is Lionel Messi, who is one of the top performers in any sport, one of the most valuable players in any sport. And I don't want to piss anyone off that likes Ronaldo, but Lionel Messi uses HRV. And if this guy, who is one of the most important players in any sport for his sport, makes sure that his HRV is, he's not overtraining, and he is performing at the highest caliber. You don't want to overtrain him, because when it's time to go to play, you don't want him to get hurt. Okay, so same thing with your immune system. You can have the number one immune system, very active or very modulated, and if you overtrain it, you might break it. The straw that broke the camel's back. So we have to have this pause, and we have to make sure that, the decisions that we make with our training of the immune system are sound. And that's a philosophical question. I don't know what the number of vaccines is. I don't know what adjuvants, I don't, and the only thing that we have is common sense and talking to your doctor and trusting your doctor. And that's the only thing that we have. I could talk to you forever, but before we go, I want to talk about what are we doing for our patients right now. I like to separate this thing into before the infection or chronic, immune modulation, and then what happens if you get the infection. And we won't go into going into a respirator because we don't know.
Well, and that's all individual with the person in front of you, right? Yeah,
Totally.
I mean, yeah, my whole thing is, like I said earlier, let's be the world's worst viral host, aka optimize your being, your body, mind, and spirit. And I mean, I think a lot of it, you mentioned HRV. I mean, HRV has also a lot to do with sleep and recovery. So I'm a big proponent of adults getting 8 or 9 hours of sleep a night, kids more. I think we need to be either, at night, getting to bed on relatively early, not staying up till 2 or 3 in the morning now that we're all at home. I mean, I think that most of the science says between 10 and 11 for adults, and I know some people are a little later, but let's not push it too much, is a good bedtime. And really working to get sound sleep. So I use blue blocking lenses at night. I try to turn my screens off kind of early. If you have issues sleeping, certainly supplementation with melatonin may be helpful. But doing something like an HRV training, like a heart math, or even just heart-centered gratitude breathing before bed, EFT, whatever it is that gets you kind of calmed down so you can sleep well. And I think one of the biggest keys for sleep is getting up in the morning and going outside and getting some sunshine, because we talk a lot about melatonin and sleep and everything, but I think what we often forget is melatonin production starts when we're exposed to natural light.
One thing that drives me insane is people that walk around blue blockers in the daylight.
That makes no sense.
That makes no sense. Like if I lived in, in Oregon, or Seattle, and I didn't have any sunshine, push comes to shove, I would turn the brightness on my computer all the way up in the morning, and try to get something, to make, some melatonin.
I even use retimers in the winter, so I get the blue-green light extra special just to be in the safe side, because I always thought I was not a morning person, and I like to stay up really late. And I started getting up and going outside, especially wintertime with the dogs. But if it's gray out, I'm throwing the retimers on. It totally changed my sleep cycle. I always slept well, but I can get to bed a lot earlier. I can get up earlier, and it's like helps your cognition. So I think it's critical, and the one thing I don't want to forget is outside and fresh air is critical. When you look at like the Spanish flu pandemic of 1918, osteopathic physicians compared to other physicians had like a tenfold decrease in mortality. And they would say, go outside and get some fresh air and walk. And if you can't, if you're lying in bed, a couple times a day, the family would be instructed to open the windows and also to, while they're lying there, shake their feet up and down, like to make a fluid wave to help the lymphatic fluid drain. So any bit of gentle movement, some exercise, some fresh air, and some sunshine will help. Because we keep talking about all the zinc and quercetin, vitamin D, and selenium, and all how it helps with the immune system. But man, I want to start my D with the light. A lot of people do need D supplementation, but all these really important. One of the other things I think people need to focus on is just eating a really comprehensive diet. And I'm not here to tell somebody to do, paleo or keto or whatever it is. I think that there's a lot of personal flexibility there, and there's also condition-specific things. But I do think we all should be on a plant-based whole food diet first and foremost, meaning lots of veggies, some fruits, diversity, rainbow, so that we can get our vitamin A, our zinc, our C, our quercetin from our food. And then if we want to add in meats and beans, you can do that. But a lot of what you do before you get exposed to the coronavirus is really just eating a really good diet, sleeping well, getting some fresh air. And I guess the last piece of that would also be taking time to chill out, right? And that goes back to the HRV. There's tons of studies on improving immune function with a variety of things, from meditation to EFT to like heart math training. There's all kinds of different things you can do. But if you pick something that helps you calm down and you sleep well and you move your body a little bit outside and you eat a diverse diet, you're going to have a great foundation. And it doesn't cost like a lot of money to do all this. It's not like you have to take 100 supplements. So that's the place I start.
For my patients, and what I've been putting out there, I like what you say about being the worst host for a virus. The way that I've been explaining it is I want my immune system to be fully equipped before we go into this fight, okay? And I'm not a big supplement guy, but at this point, having a multi could be a good thing, especially with not having access to as many foods as possible because of supply chain issues. So having a multi right now could be, good. I've been recommending using Chronometer if you want to geek out on this and put in all of your foods and see how you're doing in micronutrient status. And then I like to do just good diet, exactly what you said, just having all of the background things working in a chronic state. And then if you were infected, that's when you start, putting together a protocol based on the presentation of the patient. It's interesting what you said about melatonin in helping the lymphatic system, because we know that melatonin at higher doses, it's kind of like an antioxidant. So again, reducing inflammation. But that's where you work with your doctor and then you decide what are your pitfalls and how to overcome them.
Yeah, I think that things like, making sure your D is up, which, acutely, if you're not working with a doctor at the moment, you can certainly safely do that in the short run. And some lower dose zinc and some regular quercetin are probably things that if you start to think you're getting sick are going to be really safe, and I think when I look at those, though, I see a lot of like super high dosages being used, and I'm like, I don't know that we need to do that on our own. I think if we're working with a provider who can specifically do it, but I do think that when you look at what people are doing in medicine, like with prescription medicines, and they think might work, zinc and quercetin are kind of up there. But again, it's very individualized, and I'd rather get it through food. Although in my sort of multi and my immune support, I'm getting a little bit, extra just to be on the safe side. But I'm not ODing on it. I'm just doing a little bit. And I mean, it's really hard because a lot of people are saying, what you have to do is you have to do hydroxychloroquine and azithromycin and zinc and quercetin, and you'll get better. And I'm like, well, the problem with that thought is you treated two people like that, and statistically speaking, 85% of those people are going to be fine, like completely fine. They're going to get better in a week on their own. So the question is, are a lot of these reports that are coming out because we use the medication, because we use a supplement, or because the disease ran its course? And like I said, I'm not going to, you and your doctor really need to make that decision because, again, I've had so much experience in the ER and the critical care unit where you have to make a decision based on what is most likely to help you and least likely to make you worse, and that's individual. But as a general rule, I mean, we can't make those decisions at any large rate at this point because we just don't have the evidence. So, but I do know that there's a ton of studies showing that eating a diverse plant-based diet with meats in it if you want and stuff usually is pretty good. So I start with a lot of that,
Yeah. And that's the thing, is this treatment just not killing your patient? It's like, is it safe enough that you didn't kill them and that's why they got better? It doesn't necessarily mean that they got better because of the treatment. They just didn't get worse.
Right. And that's the thing. Like, I want all this to work, right? Like, my God, if we could get a study that showed hydroxychloroquine worked, that would be amazing. And one of the things that might be coming out of it is a lot of people are starting to go, maybe hydroxychloroquine and zinc in the hospital. Like, so we're starting to see that some of the hospitals are starting to look at maybe vitamin C. Wow. Like, we know it's got some antiviral properties, but now the conventional system is starting to learn to be a little more interested. And I'm hoping in the long run, we learn a couple things. And one is that the conventional system realizes that the more nutraceutical natural medicine perspective has more options that we could join together. And it's not one or the other, it's maybe together. And the other thing that I've found that I just always like to say is, despite physical distancing and all the negativity that's been going on in the world, the fear of coronavirus, the negativity before even this happened, man, the world has really come together because of this thing. And most people who are doing things are actually making changes in their lives, not only to help themselves, but to protect the others around them. Because physical distancing doesn't, if I'm sick, doesn't help me. It helps everybody else. So by staying away from other people at a distance, we're actually helping our fellow human beings at a rate I've never seen in my whole life. So I'm hoping that in a weird way, we start to act a little bit more like nice, loving human beings at the end of this whole thing. And we bring maybe Western and sort of natural medicine, allopathic and everything else maybe comes together a little bit more so we can have something good pop out of this whole thing.
Yeah. Advance the integrative approach to medicine.
Right. And that's the thing. Like, integrative doesn't mean herbs only. Integrative means the best of whatever we need, whatever's available.
Yeah, the best of our toolbox. Yeah, the best of our toolbox.
Right.
Sometimes, we use, a little bit of medication. Sometimes we suggest using a vaccine. Sometimes we tell you to go and walk around barefoot on the grass.
And they're all wonderful in the right time and place.
Yeah, exactly. And we could talk about this forever, dude, but I know you're a busy man. So let me ask you, how can people get a hold of you? Where can people look at your blogs and your social media? And then you have a little, an experts panel summit coming up, don't you?
Well, so I'm at originsofhealth.com. And if you put a /coronavirus after there, I have a coronavirus resource page. I did a 3.5-hour expert summit a couple weeks ago live, and the replay is available on the originsofhealth.com /coronavirus page. I also have a coronavirus cheat sheet on how to prevent getting it, and also the my five top tips for staying healthy going into this, which we covered all of them, not in any real order. But and then I have all my coronavirus and other blogs over there. And on Facebook, you can check out Origins of Health. And I'm doing a lot of stuff there and more things coming out all the time to try to help folks. And then also, Instagram is just Dr. Tom Moorecroft. So if you head over to our Facebook page, you can see the link for the event. I'll get up on the website this weekend. But this coming Monday, Tuesday, and Wednesday, we're doing another 3-night series with experts. Focusing a lot on both on food and the mental emotional side of things, families, kids, as well as personal health. And so we're going to do 3 nights. It's going to be just really spectacular. So that's available live coming up. And then also the replay will be available, and all the coronavirus events are free to everybody so that they can just get the valuable information that they need to know now.
That's awesome. Well, thank you so much, for giving us this update. I wanted to put another podcast together about this and what we know and what we don't know, which is more frustrating. Dude, I hope you and your family are safe. Say hi to your wife for me, and I'll talk to you soon, man.
That sounds awesome, brother. Thanks for having me. Love chatting.
Yeah, dude, I'll talk to you soon. See ya.